I'm Howard Chansky, Vice Chairman in the Department of Orthopedics and Sports Medicine, and it's my pleasure to welcome everybody here today, including some of our visiting medical students. And this morning, our topic is atypical fractures that are induced by bisphosphonates. And our first speaker is going to be Jennifer Hagen, one of our residents who's going to talk about the history of the development of bisphosphonates and how these fractures initially were recognized, and I think even some of maybe the legal aspects that have arisen. And then after that, Dr. Ott, our metabolic bone disease expert, is going to talk about the basic biology of bisphosphonates and what the latest theory is as to how these drugs that are supposed to prevent fractures may, in rare circumstances or even more frequent than that, actually cause them. And then finally, Jim Krieg, one of our Harborview trauma surgeons, is going to wrap things up and talk about the surgical treatment of these atypical fractures. So Dr. Hagen will start off.
Thank you, Dr. Chansky. So we're going to start with two cases I will discuss throughout the presentation. The first one is of an 88-year-old female of Asian descent with an insidious onset of left thigh pain over a series of weeks. No reported trauma. Her pain is worse with ambulation, but she is able to tolerate standing and sitting. She's on exam, no pain or range of motion of her hip, and her pain is reproduced when you palpate her thigh. She has a history of osteoporosis and has been on Fosamax for an unknown amount of time. This is her AP pelvis x-ray, and again, it's the left hip that we're concerned with. This is a close-up of her left femur. Patient was seen by her primary care provider. Her films of her left femur were interpreted as normal. And I'd like to draw your attention to this abnormality about the lateral cortex of her proximal femur that we'll go into a little bit later. So, if this patient were in your office, what would you do next? Continued observation? Would you aspirate her hip joint? Any further imaging, or would you propose a surgical intervention? These are just things to think about. And this is for the residents in the room. When reading results from a DEXA, what does the T-score represent? These questions are often on our in-training exam. So is it the standard deviation below the average bone mineral density for a matched 25-year-old with osteoporosis being -1 to -2.5? Standard deviation below for an age-matched cohort? And the same options with osteoporosis being defined as less than -2.5. Think about that for a second. So T-score is actually a standard deviation for 25-year-olds, and osteoporosis is defined as a T-score less than -2.5. Second case, 76-year-old female, again of Asian descent, bilateral thigh pain for 6 months. She fractured her left femur after kicking a step. There was not even a fall associated with it. She also has a history of osteoporosis. She's been on Fosamax for 12 years. These are her injury films. And we'll talk a little bit about the pattern, fracture pattern. This is her contralateral thigh. So she's had bilateral thigh pain. She only broke the left side. This is what her right femur looks like. Again, I'll draw your attention to that abnormality about her lateral cortex. This is what she looks like on the lateral. You can still visualize it. So her fracture was fixed. Fosamax was stopped. After her surgery, the contralateral leg that had been hurting her before no longer hurts. This is her DEXA 2 months after her surgery. So she's now in the osteopenic range. So what do? Now her right thigh does not hurt, but she still has that abnormality on her x-ray. More imaging? Do you observe her with serial radiographs? Do you repeat her DEXA and consider restarting her bisphosphonates? Or do you sign her up for a prophylactic nailing? Again, all of these we'll talk about. So a quick history of bisphosphonates. They were originally developed in the 19th century and were used by farmers to soften water and irrigation systems in orange groves. In the 60s and 70s, they became a medical use because they were used to treat Pagets and heterotopic calcifications. First approval for osteoporosis was Fosamax. It was developed in the 1990s, and the patent was approved in 95. So these have been in general use since 1995. 2005 to 2006, we started having reports of jaw necrosis and some concern for esophageal cancer. There are class action lawsuits ongoing. And then in 2008, the patent expired on Fosamax, and there are several generics now available on the market. Again, the general mechanism of action, and it depends on which bisphosphonate you're speaking of, but in general, they inhibit the enzyme that osteoclasts use to form the ruffle border, which is the acidic border that allows them to resorb the bone. And the osteoblasts are secondarily inhibited because there is no longer bone resorption, so that pathway is shut down. But we know it works, and we know it works to help prevent typical hip fractures and osteoporosis. Over 40% of white women over age 50 will sustain a fracture within their lifetime. It's a fairly large number. There was a very large trial following around the approval of Fosamax in 1996 that showed that after 3 years of Fosamax, there was a relative risk reduction of 0.55 for vertebral fracture, 0.5 and 0.5 for wrist fracture and hip fracture, so a very large reduction. And the hospital discharge rate for women with hip fracture decreased from 600 per 100,000 to 400 per 100,000 in the decade following 1996. So they do work. So what went wrong? Around 2005, reports began surfacing in the literature of these atypical femur fractures with osteoporosis. And there were some concerns that these were fragility fractures and stress fractures that the patients weren't able to heal because of their bisphosphonate use. This started a large number of multi-center cohort studies, all with conflicting reports. So what do we mean by atypical fracture? The majority of these occur within the proximal 1/3 of the femoral shaft, but they can be found anywhere along the diaphysis. So they're not femoral neck, they're not intertroche, they're not the classic hip fractures that we worry about in older women with osteoporosis. This is a diagram, again, of the general anatomy of the femur. So they're anywhere between in the subtrochanteric area down into the femoral shaft or diaphysis. Most of them occur from minimal or virtually no trauma. For example, our patient kicked the curb and broke her femur. So these are very low energy injuries. They can occur bilaterally. When they are complete, they generally have a transverse or a short or oblique pattern with a large medial spike. When they are incomplete, they only involve the lateral cortex. So there's that beaking that we saw in the other films. Often, again, they have the thickened lateral cortex and periosteal reaction, which has been referred to as beaking. And there is prodromal thigh pain in about 70%. So that's usually their presenting symptom. So one of the first big papers that came out about this was by Abrahamson et al. In 2009. They had two large register-based studies that compared over 20,000 proximal femur fractures. The mechanism, high energy versus low energy, unfortunately was not recorded when they stratified, and the x-rays were not reviewed. So we're only going by radiology reports that these were typical versus atypical fractures. They did not find a difference in the ratio of diaphyseal fractures to hip fractures, so they found that they were about equal. And they also did not find that with longer use of bisphosphonates that the fracture pattern shifted from a typical hip fracture to an atypical. So they concluded that this increased risk of fracture was just the underlying disease, that this was an osteoporotic fracture that we were seeing. So this followed an FDA drug warning back in March 2010 that showed no clear connection between bisphosphonates and femur fractures. Bone Mineral Research Task Force had 28 experts that reviewed all the available literature. They were charged with multiple tasks, including to develop a list of possible mechanisms for these fractures. Among their lists was alterations in normal pattern of collagen cross-linking, and Dr. Wright will get into some of this, microfracture, microdamage accumulation, increased mineralization from the bisphosphonates, variations in the rate of bone turnover. They concluded that the atypical fractures appeared to be more common in patients treated with bisphosphonates for greater than 3 years. They recommended considering a drug holiday for patients without a recent fracture and who had a T-score that was not in the osteoporotic range. And if they had a patient with thigh groin pain, they recommended evaluating both femurs with plain radiographs and or some type of advanced imaging, either MRI or a bone scan. So following this, 7 months later, the FDA responded with another drug warning that said, although they don't know what the optimal duration of bisphosphonates are, they do appear that there might be some link to long-term bisphosphonates and these fractures. They added a new limitations of usage statement in the package for the medications. There's also a medication guide that's going to be given to patients describing these symptoms of the atypical fractures. And they recommended considering periodic evaluation of patients that have been on bisphosphonates for greater than 5 years. They didn't specifically recommend a drug holiday. The last study I'm going to bring up is the one that was done in JAMA this year. It was done in Canada, looking at femur fractures in women over age 68. 716 case patients versus 3,500 matched cohorts. The groups are subdivided into use of bisphosphonates from 100 days to 3 years, 3 years to 5 years, and greater than 5 years. They found that people with bisphosphonates greater than 5 years had a 2.74 increased risk of diaphyseal femur fractures. But again, they weren't looking at the x-rays, these were just the radiology reports. They did find that extended use was found to result in a decreased incidence of typical hip fractures, which again has been shown before. Bisphosphonates should have some protection against hip fracture. And then they concluded that 1 in 10 femoral shaft fractures could be prevented by limiting extended use. So now we're kind of going to talk about where we go from here. I'm going to bring up Dr. Ott.
Okay, thank you. Okay, so this is an advertisement that was in a lot of newspapers around the country about 10 years ago that was really striking. And this is for Fosmax, a breakthrough treatment, completely non-hormonal, truly rebuilds bone, which is actually not true. So I'm going to spend just a couple of minutes on a pathway of some of the mechanisms of how these drugs work, because they don't rebuild bone. And it's been a myth perpetuated for the last decade, and it's really about time that you knew that that's not the way it works. Now, one of the really important things in these studies is that the fractures were only prevented in the patients who had osteoporosis. And if your bone density was not actually in the osteoporosis range and was in the, quote, osteopenia range, then it didn't really help. And in fact, in the largest trial that was done of alendronate, if your bone density was better than -2, there were actually 14% more fractures with the alendronate than with the placebo. But most people aren't aware of that. So what do they do? Well, as Jen said, they decrease bone resorption. That's their primary mechanism of action. Because of that, they reduce risk of perforation. And what's happening in bone as you get close to osteoporosis is that you're perforating little areas of your trabecular network. And you can get resorption from each side and perforate it, and then you lose the architecture of the trabecular bone. And that's what makes your bone weak. And if you do that enough, that's what's going to cause your trabecular bone to collapse, like in a vertebral compression fracture, or the typical osteoporotic fractures in your wrist. They're the trabecular bone in your hip. This reduced risk of perforation increases your bone strength. And it particularly increases your bone strength compared to people who are taking placebo, who are getting worse and worse and worse. And you remember all of these studies are actually comparing the placebo group to the treatment group, and the treatment group looks better. A lot of that's because the placebo group is getting worse, and they're perforating their trabecular network. Now, as a consequence of reducing bone resorption, you decrease the bone formation rate. And so the osteoblasts are no longer forming any new bone. What difference does that make? Well, you're always remodeling your bone. That's what makes it different than a pillar on one of the freeways. And if you're not remodeling your bone, then the material of the bone gets older because it's not getting refreshed. And it gets denser because the newer bone is less dense than the older bone. And it's like, you know, the tip of your nose. The cartilage doesn't have any mineral. It's very flexible. It's not very dense. It takes about 3 years, at least, to fully mineralize a piece of bone, a piece of new bone. So you increase this. Now, this makes your bone density go up. And that's the major way that your bone density goes up. Not that you've made any new bone, but that the bone you have is getting denser. You do make a little bit of new bone in the very beginning because any of the resorption cavities that were ongoing, that were filling up when you started the drug, will continue to fill up. And that usually takes anywhere from 3 to 6 months. So for the first 6 months, you actually get a little bit of increase in your bone volume, a few percent, and that does increase bone density, but we would not call that building new bone, not like a drug that actually causes you to make new bone. And the main way that your bone density goes up is that your bone is denser. And that's not the way most people conceive of it. And finally, since your bone has got more mineralization and the bone is literally older, it gets cracks. We all get cracks in our bone. Every time you trip or step a little funny, you'll get a micro crack. And they'll accumulate. And that can decrease the intrinsic toughness of the bone. And we're not sure if in addition, the bone is getting more brittle. But this is a possible mechanism of why the bones can get more brittle. And the fact that you're not remodeling your bone, I think, is important. And it takes a while for that to matter. Your ordinary skeleton is turning over about once every 5 years in your trabecular bone, about once every 8 or 9 years in your cortical bone. So you're not going to notice any of these changes of slowing down the bone formation for the first couple of years. And the studies only lasted 3 or 4 years. So the concern is, what about the long-term effects? Do we have really good short-term effects and possibly harmful long-term effects? And that's what I was asking when they first came out, just because of the way they worked. And it looks like now they do have some, and we'll talk about those. And the first report questioning this actually came out in 2004 of patients with unusual fractures. And they did biopsies, and they did tetracycline, and this is what a tetracycline label looks like under fluorescent microscopy. You can see 2 nice double labels. These were controls. These were the patients with these unusual atypical fractures that were in cortical bone sites and not our more classic osteoporotic sites. And this is just actually a data slide to try to persuade people that the bone formation rate actually is low. And in the bone field, it's very common to say, well, you know, we've done bone biopsies and we can still see some tetracycline, so everything's fine. And here's the actual data to look at. So these little dots each represent a study where they did a bone biopsy in a group of people and measured the tetracycline label. And the length of the label is directly related to how much bone you're forming. And here we have children. They have nice, high, vigorous bone formation. These are normal premenopausal, adult women, postmenopausal. With osteoporosis, you start to get more variability. These are the dots of studies where they've been treated with bisphosphonates, and these are clinical trials where we have before and after. You can just see that these bone formation rates are substantially lower than normal people. Okay? And here's a few other comparison kind of medications. Here's denosumab, which is the newest kid on the block, and it's even inhibiting your bone resorption and formation so much that 1/3 of them have no tetracycline whatsoever. Here's teriparatide, which, especially in the beginning, actually does build new bone. A photomicrograph of what these little cracks look like. Here you stain it with fuchsin, and you can see they're small little cracks. But if they accumulate, they can turn into big cracks and turn into fractures. This is one study that I think is interesting, looking at the baseline bone turnover rate. So this was the FIT study. That was the large study that got alendronate approved in the first place. And when they looked at those who had osteoporosis and divided them up into low, medium, and high bone turnover at the baseline and looked to see what happened to their fracture rates, the ones who started out with low turnover didn't really have any improvement. The ones who started out with high turnover had some reduction in their fracture rate. It wasn't all that much. Those patients who have high turnover, these are the ones who are resorbing a lot of bone. These are the ones who are perforating and are about ready to fracture. And if you stop that with the alendronate, you have many fewer fractures. And that's enough to drive the whole thing and to cause these nice reductions in overall fracture rate. Now, we don't use this information clinically at this time. Pretty much right now, everybody gets bisphosphonate just based on your bone density score. But I predict that in the future, especially when we have better anabolic drugs, we're going to start to tailor our treatment. Why give a drug to block bone resorption if you don't have bone resorption that's high in the first place? But that's what we're doing right now. So what happened to fractures? If you had 4,000 women and the T-score was better than -2, half as many That's what most people think. 23% reduced, 10% reduced, but 14% greater is the right answer. All right, so some reports that started coming out. This was the case report of a very unfortunate young boy who had a high alkaline phosphatase. And any of you who have rotated through children's know that children are supposed to have a high alkaline phosphatase, but this guy's doctor didn't know that. And gave him the wrong diagnosis of juvenile Paget's disease and started giving intravenous bisphosphonate, intravenous pamidronate, at doses far higher than we would have even used if it were juvenile Paget's disease. And he went from a fairly normal appearing bone to this idiopathic osteoporosis. And what's interesting, he can't model his bone because you're blocking both modeling and remodeling because your osteoclasts don't work. Now, this was not good bone, and this boy has been fracturing. And of course, once the bisphosphonates are in your skeleton, you can't get rid of them. So this was a sad case, but it demonstrates what can happen when you overdo it. Now, what about the clinical trials of long-term? There's not very much information. But there's one study called the FLEX trial, and it's about the only randomized trial that we have to see what happens after you stop. So within the first 4 years, this was a placebo-controlled trial, and this is the alendronate bone density going up like we always know. And here's the placebos going down and getting worse and getting fractured. Then after 5 years, the women who were on the drug were re-randomized to either continue on it or to take a placebo for the next 5 years. So these women had been on it 5 years and stayed on it, and you can see that they stay stable, which is one thing to point out. You don't continue making bone like you do at first. You see, as soon as you're about 3 years, you're now fully mineralized, and you're not making any more new bones, so your old bone is just sitting there, not changing very much. If you stop, your bone density does come down a little bit. But interesting, this is because the mineral is coming out. You're not actually losing the volume of the bone. Your bone is now, the mineral density is coming back out again. The calcium ions are coming out and water is going back in. This is the urine N-telopeptide. That's the test actually developed by R. David Ayer, which measures whether you're resorbing bone. And as you can see, when you start a bisphosphonate, it goes down very rapidly and profoundly, and then it stays down while you're taking it. But interestingly, it stays down just as much for the next 5 years, whether you continue taking it or whether you stop. And that's because it's attached to the mineral of the bone. So this bisphosphonate, you stop taking the pill, but you don't really stop. It's still there, it's still in your skeleton, and it's still active up to about 5 years after you stop taking it. Now, what happened to the fractures? This is the really important point. This is the group that took alendronate for 10 years in a row, and this group took it for 5 years and stopped for 5 years, and there's no difference in the vertebral fracture rates when you measure them by X-ray. There's no difference in the overall fracture rates. So it doesn't really matter if you keep taking them or if you don't. So why should we keep taking them? Why should we be prescribing them after 5 years if they have the same number of fractures? That's one of the main reasons that the FDA is saying, reevaluate after 5 years. Even if it's safe, it's not effective. So we don't want to prescribe and pay the expense of taking a drug if it's not going to have any benefit that the patient can tell. Okay, so now these subtrochanteric fractures. One study, 13 fractures. This was from Singapore. These were atypical fractures of the shaft. 9 were taking alendronate. Here's another one. This is from Joe Lane's group in New York. 69 fractures, and 36% were on alendronate. So is this something new or just other osteoporotic fractures? This is the fact that some of these are just other osteoporotic fractures. And there have been a few fractures of the femoral shaft all along. You all know that. And here's, for example, this is a 19-year-old healthy recruit to finish military, and he's got what looks for all the world like our atypical fractures. So they do happen, but they don't happen very much. And this was a study done before bisphosphonates were ever invented from the Mayo Clinic, where they were doing a lot of fracture epidemiology. And I want you to pay attention to this line here are the subtrochanteric and distal fractures. This is the incidence per 100,000. So up until 80 years old, you're looking at only about 10 per 100,000 cases of a non-traumatic femur fracture. I mean, most of these femur fractures in relatively young people are caused by trauma. When you get to be 85, the diaphyseal ones do go up to about 40. Okay, so that's the baseline rate. They're very rare. Now, this is the typical versus atypical, and I want to point out, you've seen the features. They're transverse. They're a little thick here. The typical ones look, spiral, comminuted. The cortices are thin. If I were going to give an ICD-9 code to these fractures, it would be the same code, okay? And so all of those studies that looked at registry, that looked at ICD-9 codes, can't tell the difference between this and this. You can tell the difference, but you have to look at the film. If you just did your study based on the code, you won't see a difference. And so all of the studies that were based on ICD-9 codes and didn't look at the x-rays can't find anything about atypical fractures. And so I'm just going to dismiss them all just like that. That's almost all of them, except our study, which I'm going to show you. So the case identification, diaphyseal region, transverse fracture. You can get a little beak here. You can get a little bump or something there, flaring. And you have to be careful that when you do your studies, you use the right cases. So this is a group that actually looked at the cases. And this was the one that was just reported, and it's from Sweden. So they looked at 1.5 million women, basically everybody in Sweden who was over 50. They found 12,000 femur fractures. Of those, 1,351 were in the diaphyseal region by using the codes. And then they looked at the ones who just had mild trauma because they knew whether they had trauma. And then they looked at the x-rays, and here's where we get our real separation. Only 59 were atypical, but 78% of them were on a bisphosphonate, and the rest of them were ordinary. And so the relative risk here was 5 times higher if you were taking a bisphosphonate. And if you were taking a bisphosphonate more than 2 years, you were 8 times more likely to get one of these atypical fractures. So that's from Sweden. Now, we did a study using the data from Kaiser. This is Kaiser, California. For 2 years, the femur fractures all pulled out by ICD-9 codes, so there were 15,000 of them. The radiographs were reviewed, and they were in the diaphyseal region were 1,400, and 135 had this pattern of the atypical fracture. And here's the characteristics of those patients compared to a literature review of everything published up until 2009. The second largest series, which was from Australia, that had 41 cases, and then our series that's the biggest, and it has 135 cases. You can see 71 and 67% had preceding thigh pain. They were bilateral, almost half in the earlier studies, not quite so many, although this number is going up. Some of them are starting to get their second fracture now. Age is relatively young. I mean, for an osteoporotic fracture, you saw that curve before when these fractures start going up. It's 85, not 65. Duration of use in bisphosphonates, about 77% have taken them longer than 5 years. In these 2 studies, the mean was 6 to 7 years. Half of them had a prior fragility fracture, and I point this out because some of the studies have only looked at people who first had a fracture to get into the study. And half of our cases never even had a fracture. They weren't thin, 60%. And look at the bone density average was minus 2.2. A lot of these women actually should never have been put on the drug in the first place. It was wishful thinking. It was hope. It was hoping that here's somebody who's 50, who has she's a little below average. I'm going to give her this drug so she won't get osteoporosis when she's 75. Based on a study that took 4 years. So, we're hoping that we can prevent aging of the bone, but we're not doing it with these drugs. And this, here's the age at the time of fracture according to the duration of years. You could say, well, obviously somebody on 10 years is older. But it turns out in this study it wasn't, because a lot of the women were young. So the ones who were on it the longest time, 10, 11, 12, and this is as long as you could possibly be on it, because that's when the drugs came out. Some of these women started when they were in their 40s. And so there's no correlation. T-score did get a little better with longer use. And there's some of them were really pretty osteoporotic down here, but look at some of them had bone densities that I would love my patients to have, as long as they weren't caused by bisphosphonate. And here's the incidence. So this is actually a computed incidence. This is not published, and it's not supposed to be disseminated anyway. Here's the years of exposure from 1 year, where the rate is very low, to 13 years. And there's pretty big error bars around these because there's not that many cases, and there's not that many patients. But you can see that there's definitely a very significant difference between the ones who've been taking it for a prolonged time compared to the people who took it for a short time. And it's especially important to look at the ones who only took it for 1 year. So there's a lot of women who take the drug for a year or less than a year, and then they quit. And study after study, it's about half of them. So the women who were prescribed the drug had the same indication for the treatment as the ones who kept taking it. It doesn't mean they were exactly the same kind of patient, but at least they had the same indication. So these women who took it for 1 year had about the same amount of osteoporosis as these women. But you can see, and this is the strongest evidence to date that the drugs actually do cause this problem. Now, before I turn it over, what can we do? Teriparatide is the one I've already mentioned. Teriparatide actually stimulates the osteoblasts. It truly makes more bone, new bone. When you look at micro CAT scans, you can see that these trabeculae are actually getting thicker, and you can see it on the tetracycline labels. One very interesting study. Now, this is not related to bisphosphonates. This is just ordinary old stress fractures, and you're going to be hearing a whole lot about this. This was all everybody was talking about the last ASBMR meeting. These are ordinary stress fractures that were caused in an animal model of the ulna, and they have a control here, and this is the tetracycline. This is a alendronate, and the alendronate ones don't heal very well, because you heal stress fractures by dissolving the fractured bone and filling it in with new bone. You can't dissolve it. So all you do, and you can't fill it in very much. There's a little bit of tetracycline, but nothing like control, and nothing like teriparatide, which seems to speed the healing of these stress fractures quite a bit, and studies are in progress. This was a paper that I thought I'd better put in because it came out last week in the New England Journal. It was a biopsy at the site of fracture, right at the tibia, and they said, oh, look, you can get bone formation there, so this is not caused by decreased bone formation. I'm not sure that you don't necessarily have to have completely zero bone formation rate, especially right where you had a fracture, because the fact that there was a fracture there means that there's a lot of stimulus for forming bone. And they could find a little bit of formation, and we've actually done this in our first ones here in Seattle. We see a little bit of formation, but it's not adequate to heal the stress fracture. That's the important point. Not that it's completely zero, but that it's inadequate to heal the stress fracture. Here's the little micro damage I was talking about. This is a study of naive women who had not taken any, they had osteoporosis, had not taken any bisphosphonates. This had taken alendronate for a while. Baseline biopsy, they had more microcracks. But after a couple years of the teriparatide, they came back down to the normal level. So this is circumstantial evidence that if we treat these people with the alendronate fractures with an anabolic drug, we can heal the microcracks. And we've been putting a lot of our patients on teriparatide because of that. And so that's what we do medically. I mean, it's up to us not to give so much of this medicine in the first place. But if we do, and we get into one of these, then you guys have to fix it. So he's going to tell you how.
Thanks. That's a great intro. And I'm going to switch gears just a little bit and talk, as Susan said, about surgical management of these fractures. Hopefully raising some questions and perhaps some answers. So first I'd like to define the problem from a surgeon's perspective and then perhaps outline some of the principles of treatment that we follow, recognizing that in those principles, as any time we treat a fracture or treat any surgical challenge, there are compromises to be seen and to be recognized, and I think those trade-offs are important for us to think about, and hopefully to give you some treatment recommendations to take away from all of this. So again, as you've heard, what's the issue? Well, it's interesting to me, it's amazing to me in some ways to think that this didn't exist 7 years ago in our world, and so this has been a rapid history to write, and again, this all came up about 6 years ago in 2005. We hear now how alendronate decreases bone remodeling, and we heard about the microfractures. So I think that, again, frames the issue quite well for us. We know as surgeons that we started seeing them in the subtrochanteric region, and now we're starting to see them in the shaft as well. But recognize that biomechanically, these are a real issue for us. The subtrochanteric and shaft regions, especially with these lateral tension failures, are a very high-strain fracture environment. And now we hear that they're histologically abnormal. When the first reports started coming up and turning into case series, it started to be recognized, as Susan said, that they were often bilateral. In a report last year in the British JBJS, half of their patients had a bilateral lesion or bilateral symptoms. And so as surgeons, we have to bear in mind that when a patient presents to us with a fracture or symptoms related to one of these, that we have to look on the opposite side. And I think there also now comes a role for prophylactic nailing. And again, the analogy that I would draw would be the slipped capital femoral epiphysis in the child. We all know that the physiology of that child puts them at risk for a bilateral condition. And I think the same has to be said for these patients. So without being able to give you firm recommendations on when to do a prophylactic nail, I think you at least have to entertain the idea. There have been recommendations, depending on the series, that one do it based on pain. Again, I don't know how solid that is. There are also recommendations that when you see a lucency in the lateral cortex, or as in this case with a bone scan that's positive. And again, I think we are far from having, or perhaps not too far from having firm recommendations, but the question has been raised, and I think as surgeons we have to pay attention to that and raise that question in our patients. Again, recognizing the principles of pathologic fracture management, and certainly these are pathologic fractures, we're taught to span the full length of the bone, and for us, typically that means an IM nail. And nowadays, we typically would use one that's a cephalomedullary nail. So our goal with interlocking this nail, again, is to try and span from the tip of the femur to the distal end. And I think, again, when these started to appear, these were geriatric fractures to us. And we followed our principles and thought we were doing an okay job. But again, we have to go back and take a step back and realize that these are not, as Susan showed, the typical fracture. And that raises for us as surgeons who think about fractures some compromises. I think, again, if you look at the milieu of the patient, these are often osteoporotic or osteopenic patients who are often elderly. And so the goal is poor bone, and we want to gain immediate weight bearing and treat it as a pathologic fracture. And so as surgeons, our principal mode of treatment will typically be an intramedullary nail. But if we look at these fractures in isolation and think about the fractures themselves, they're in many ways a stress fracture, as we've heard. They're a simple fracture pattern. This fracture begs for compression. And again, applying compression with an intramedullary nail is typically not our first mode of treatment. We would typically think of a plate and screw construct. So that's where I think the compromise starts to be engaged in these fractures. We have a patient that really begs for a nail and a fracture that really looks for a plate. And that's why I think when you look at the series of IM nails, we're starting to see lots and lots of failures. And again, as Susan mentioned, it may be, a 25, but it's up to 50% now in some series that these patients are getting reoperations. And these are pretty big series. And again, I think when you look at this and think about reoperation, that's a pretty significant event in an elderly patient. So I took a step back in looking at these cases, and I have to recognize that a lot of these cases came to me from my partners at Harborview, and so for me this represents sort of the collective wisdom, but I took a step back in putting this together and thought, why are there so many failures and what can we learn from them? So I'm going to take a few minutes to sort of focus on those failures and see if we can unwind why they're happening and maybe come up with some challenging thoughts for how to treat them. So again, if you think about these fractures, this is sort of a double whammy. These fractures are in a biomechanically challenging area, and that's sort of the way I'd put it. This is typically a subtroch fracture that has a tendency towards varus, and we know that varus in a subtrochanteric region is a real challenge to get to heal. And now we know that they're biologically challenged, so that's why I said it's a bit of a double hit. So I think as surgeons we can't forget that. This is a real difficult scenario, much more challenging than it may seem at first blush. So here's a case study. Again, this is, as we've heard now, a very typical fracture, and I'm not going to belabor the points of that fracture pattern, but this is what we're seeing. This is a case that was done, I think, following all the principles of IM nailing of a subtrochanteric fracture. So we see here the attempt to gain an anatomic reduction, avoiding varus. We see a provisional unicortical plate. We see a bone hook. Again, I don't think anybody in this room could argue that that's a very well-aligned fracture. We choose an intramedullary nail. We identify the start point. We, again, use a guide wire to start reaming that start point. And then we start to put in a nail. And again, this is something that I don't think one would see except in retrospect. But if you sort of glance back and forth from left to right, I think it's hard to miss, especially from the back of the room, that you've entered into a little bit of varus here. And again, you may say, well, that's being a nitpicker. I mean, that's really not much varus, and it's not. But as we watch this case play out, I would argue it's significant. Here's the initial postoperative film. And again, I think at first blush, most would say that's a well-done case. But if I could point out, I believe it's in a little bit of varus. And as we go to the 6-week follow-up, very early note of failure. It tips into further varus. So the question is, why is that, and can we prevent it, and what does it mean as we progress? So at 6 months, this patient was followed at that 6-week period of time thinking, well, you know, this is a device that's got a lot of strength to it. It's got a sort of a load-sharing capacity, and perhaps that will heal. But here we are at 6 months with obvious failure. It's clearly in varus, and we recognize insufficient fixation. So if I were to go back for just a second and try and look at that and say, why did that fail? I would point out, again, it's not egregious breach of technique, but there are a few things that could have been done better. And I think, again, if you look at that little bit of varus and recognize that not only is it in varus, but the opportunity to gain fixation in this proximal segment is in some ways not optimal. And by that I mean that we are gaining fixation with 2 interlocks, but the nail itself is countersunk so much that the nail is gaining very little purchase in that proximal fragment. Thinking about this proximal femur as a bit of a shell of bone where the most robust bone is outlined around the periphery, if that nail had been extended to the entry point, it would have gained an extra point of fixation. And perhaps that's what it takes in some of these fractures, is optimizing all of the opportunity to gain fixation in the first place. So we're going to take a look at another case and think about that. I just want you to think about that for a second as you see some of these other failures. This is a patient that, again, a typical scenario, presented with a little bit of hip pain to their primary care physician. The workup was started, and they were thinking about getting some additional studies, and 2 days later, the patient presented with that. Again, very minimal trauma, typical scenario, very typical fracture pattern. And the surgeon elected to do what they do for every hip fracture. And again, this may be a bit of more obvious example of what's gone wrong here, but you know, to contrast it with that other case, we've got lots of fixation proximally. We've got what the surgeon believed would be a fracture that would collapse, but again, this is not the plane that that device will collapse in. This device is a sliding hip screw type where it will collapse in this direction, but not necessarily in that direction axially. More importantly, if we look at the lateral view, again, this is the typical scenario of a subtrochanteric fracture that's a bit deformed, but again, recognizing that intramedullary nails are sort of sold as a load-sharing device that allows for collapse, it failed. And when it failed, it was converted to another nail at about 8 months, a long nail. Again, a little bit of bone graft material. I'm not sure what that was. I didn't see the old op note. But again, recognition that there's just not ideal alignment of this fracture. So it presented to one of my partners at about 20 months after their original fracture with the nail that was broken. You can see removal of the nail. You can see a lot of the area where the device had sort of hollowed out the bone from lots of cycling. And it was treated with this, which again, wouldn't certainly be first line of treatment for most elderly fractures, but it goes back to the basic principles of trying to obtain compression at its simple fracture site. And so again, if we could just point out, this is a device that gets ideal fixation in the proximal fragment. It's the old 95-degree condylar blade plate. You can see from this screw hole right here that it's been tensioned. And you can also see that there's a lag screw across it. So again, basic concepts, basic fixation principles of trying to obtain compression, and you see at 6 months out. But again, this is a success in many ways, but I would remind you that this is over 2 years after presentation from a little bit of thigh pain. This is an interesting aside. During the course of the follow-up for that plating, somewhere in the mid-treatment, the patient was complaining of a little bit of pain on the opposite side, and so this is where the learning occurs. The surgeon that plated it recognized that that subtlety right there was the beginning of the same story evolving on the opposite side and was treated with a prophylactic nail. So again, without firm guidelines on when to use prophylactic nails, I think we can all recognize that that side will have a much smoother course than the side that ended up with a plate. So here's another patient that again presented with a typical story of hip pain, vague hip pain. The primary care physician that saw the patient saw, a pretty bad spine and see them off and on over the years for a bad back. It's a patient that has obviously had osteoporosis. And so the workup commences. And I think this is a not unfamiliar story. This is a patient who starts getting injections for hip pain, who starts getting advanced imaging, and lo and behold presents with a fracture, which is treated with an IM nail. Again, a pretty routine procedure for many surgeons thinking that this is a hip fracture. Again, a long nail with fixation up into the head. Again, I would point out that I believe there's enough varus here to cause a gap on that lateral cortex. Certainly we would have concern about that much cerclage around the site of injury. And so now you've taken a situation of biomechanically challenged fracture, left it in a little bit of varus, and perhaps made the biologic situation even worse with cerclage. So of course, over the course of 10 months, this is now 10 months after surgery, a year after presentation, the patient is still having pain, still has lateral cortical deficiency, and ends up failing that device. And again, same problem, same solution, perhaps not a one-size-fits-all, but again, just to get you in the mode of thinking that perhaps the immediate nail is not going to be as successful as in the typical fractures that we normally see. And here he is at 2 years, or she is, I'm sorry, at 2 years post-op. Again, a successful result, but a 2-year course. So the things that I've thought about as I went through this are, number one, think about the bilateral risk. We all see these patients in our practice, and we're so focused on solving the problem at hand that we may not think of the global problem that really presented, and that involves the opposite side. I can't give you firm guidelines on when to use a prophylactic nail, but I would raise the point that a patient that is symptomatic, if you can get advanced imaging that shows the lesion, whether that's an MRI or a bone scan, and certainly one that you can see a lucency on the lateral cortex, I would strongly urge some thought and discussion of the risks and benefits of a prophylactic nail. I think it's extremely important when treating these with a nail, and again, I don't say that you shouldn't treat these with nails by showing failures. I would simply point out that any technical imperfection is likely to lead to a much lower success rate than you're used to seeing in hip fractures. And so I think, again, the lesson that we've learned in subtrochanteric fractures is you cannot allow any varus. I think any varus at the end of the case is a setup for failure in these. They already have a lateral cortical tension failure, and now you're increasing the tensile forces on the lateral cortex by leaving them in varus, leaving a gap over there. And I think that's a very real problem for these patients. I think optimizing fixation, again, recognizing that our nails are not necessarily a one-size-fits-all. Most of them have extended end caps. They have other ways to achieve optimal fixation in that proximal fragment. And I think, again, in a situation where you're dealing with a biological challenge, as surgeons, we have to try and do our very best to create an ideal biomechanical environment and leave it up to our colleagues to try and improve the biologic environment and hope that these patients can heal in a timely fashion. Watch for failures. They're very, very common. Again, up to 50% in some series. That's a significant concern that, again, we don't typically have in hip fractures. And I think that when you see these failures early on, when you see 6 weeks out falling into varus, I think it's imperative to act. I think that if you continue to watch these patients, you're doing them a disservice by allowing them to continue to get deconditioned and live with a fracture that you could probably deal with in other ways. And think about a plate for a delayed union. Again, I would not ever go so far at this point as saying use it as primary mode of treatment, although I would give the interesting caveat that there are surgeons doing that. That is yet unproven, but I do think that when you're faced with a delayed union or you're faced with a hardware failure, again, this is not a situation where the knee-jerk reaction to a failed nail is an exchange nailing. I think you ought to give long and serious thought to doing a plate for a delayed union to allow for compression. Thanks.
So we're going to go back to the original cases that we presented. So as a reminder, case 1 was an 88-year-old female who had had thigh pain for several weeks. She presented again with that irregularity about her lateral femoral cortex. This is her bone scan, and it's actually flipped, so you can see that she does light up at that area. So she underwent a prophylactic nailing. By 2 weeks, she was walking with a cane, and by 6 weeks, she was walking without any assistive device and had resolution of her pain. No complaints of pain in the contralateral leg. She had been on Fosamax, was stopped by her primary care provider. Now she essentially is treated with this nail. So now what do? Do you restart the Fosamax, or do you consider something else?
Oh, we put them on teriparatide.
You put them on teriparatide?
Yeah.
Okay.
unless there is some contraindication. I think if we would have put some of those on teriparatide, I mean, you're trying to put a piece of hardware into something that's brittle. You know, I mean, if you're operating on glass, it's going to be harder than if you're operating on something that's got a little bit of pliability. So I think maybe the combination of something that's helping the material property of the bone with the surgery is going to be better than putting them than one alone, although there's no studies because it's too new.
Can I ask a question then as a follow-up? I think the obvious question for me then is why not put all patients on teriparatide? Why put anybody on Fosamax if your sort of fallback position when they have a problem on this drug is a different drug? Why not just start with it?
Because it costs $1,200 a month, and
That's
the
what I thought.
insurances won't pay for it. And it only works for about a year.
Okay.
So there you are after, you know, I mean, if you're starting out fresh with it, it definitely works better. But after about a year, it's no longer anabolic. So you spend your 1 year at the best time that you can. And that's not always at the very beginning.
And you mentioned contraindications to it?
If you have cancer, kidney problems, if you already have a high parathyroid, and you have to be sure that they have vitamin D that's normal in all of these cases. That's kind of a baseline thing.
Okay. So I'm now going to open up to any questions from the audience.
I just had a question about the possible use of BMP in the treatment of stress fractures and whether we should, if there's a contraindication or whether we should be thinking about it.
I asked that question to our vice chairman. I mean, we had a case, and the question is, will it stay put in this kind of surgery? And this is, I'm going to turn that to you because I thought maybe, but he said it wouldn't stay in place, and then you'd get heterotopic ossifications, perhaps.
Yeah, I mean, it seems it's one of those intuitive things to me that if you try and sort of surround the fracture site with BMP, it may not actually enter the fracture site. And so again, you may create more bone formation outside the intended site. I mean, it's not just a matter of material, but the architecture as well. And I'm not sure that you'd be able to get it into the fracture site, but beyond that, the practical issues, I don't know. I guess I haven't heard of any experience with it, and I'm not sure what it would do. But again, I just recognize the technical challenge of getting it into the fracture site itself.
Two kind of bigger picture questions for Dr. Ott. The first is if you have a patient with a clear osteoporotic fracture in this era of cost-effective medicine, whether they should still get a bone scan to prove that they have this minus 2.5 or worse score before they start treatment in light of some of the data you presented. And then the second issue is, most of the orthopedic literature, still focuses on what a lousy job we do identifying these patients and getting them DEXA scans and starting them on treatment, and whether there's enough evidence mounting, in your opinion, that we should put the brakes on the nationwide push for Own the Bone and trying to get all of these patients on these medications in the short term, or whether the clear, say, first 5 years benefit is still clearly, the best thing to do for people.
Yeah, the first question is, if somebody has a classic osteoporotic fracture, do we need to have a DEXA before starting treatment? And I don't think you do. Certainly if somebody is 80 years old and has a vertebral compression fracture, I wouldn't feel like I needed to have any kind of bone density to decide whether to treat her. Now the second question is a little more difficult, but if you looked at the risk of these fractures, especially during those first 5 years, it's really very low compared to the really high risk of breaking your femur. And especially once you actually get in the age of osteoporosis. So women who are in their late 70s and 80s, you're still going to get a lot more benefit by treating with bisphosphonates for 5 years than you would be by not using the drug at all. So it's one of the really important points is that we talk about these because they're dramatic and they fascinate us, but it's still 1 in 1,000 cases. I mean, 1 in 1,000 people taking these drugs. And if you didn't give the medicine at all, you would be having about, 1/3 of them would be getting a hip fracture in some of these cases. So we need to use the drugs appropriately. And I don't think we should be giving bisphosphonates to women as they go through menopause to try to prevent them from having osteoporosis when they're old. I really think that should be stopped. But on the other hand, when you have elderly women who have osteoporotic fractures, they do really need to have some medicine. And this is still our our first drug of choice for most of them.
All right, so we're running low on time. I wanted to thank Dr. Krieg and Dr. Ott and Dr. Chestnut for his help.